forward to the cortex. Mediating the activity of the dopaminergic fibers, which I've just discussed, are the beta endorphin pathways, which come from the nucleus arcuatus. And therefore, by this tonic control, the opiate antagonists switch off the dopamine system, and therefore the individual theoretically should reduce their alcohol consumption. Well, in the panel on the left is an example of a study conducted using a drug called Naltrexone. And this drug is now the second drug approved for the treatment of alcoholism. It's given at a dose of about 50 milligrams per day, usually for a period of 12 weeks on a daily basis. If you look at the graph on the left, you can see the cumulative proportion with no relapse. The red line is the placebo treatment group, and the blue line is the Naltrexone treatment group. And it's obvious from this graph by the steeper curve of the red dots that those on placebo are much more likely to relapse in comparison to those on Naltrexone. One of the problems in the alcohol literature is how big is this effect? Well, as will be evident as I go on, the effect sizes have improved, but this is really a measure of the therapeutic efficacy of the drug. At the moment, they're in the small to medium range, which means that these drugs do not work for everybody, but they do work for a substantial number of people. This slide illustrates some of the other discoveries that have been shown in the alcoholism field with respect to Naltrexone. One of the important things is that with all treatment studies, not all studies are positive. And most recently, Dr. Hank Kranzler reported that Naltrexone was not efficacious in his population because the compliance rates of that population was fairly low. And what we know with Naltrexone is if you take the drug less than 80% of the time, you do suffer the risk of relapse. Also, adverse events are likely to be high with Naltrexone, particularly in populations which have liver impairment. And up to 15% of people cannot tolerate Naltrexone. This may be a particular problem in the elderly who often have other associated diseases or who may have some degree of liver impairment due for other reasons. Also, Naltrexone can produce sedation, it can produce dizziness, which would be important problems to address if this drug was actually tested in an elderly population. More recently, ourselves and other groups of individuals have been developing what's called a depot naltrexone preparation, which is really an injection that can be given, and therefore the naltrexone is released slowly in the body over a period of 4 weeks, and therefore there are 3 injections over a 12-week period. The idea behind this is that smaller doses can be given, and this would minimize the adverse event profile that most people experience with Naltrexone. Another important factor is that it's important to note that, as I've said earlier, not everybody gets fully better with Naltrexone. So the question is, who are the people who will benefit most from Naltrexone? As I've mentioned earlier or indicated, the individuals who seem most likely to improve with Naltrexone appear to those who have a family history or who have a biological disease associated with alcoholism. There have been studies of other mu-opioid antagonists. Another one is called nalmefene, and the idea of using nalmefene is that it is less toxic on the liver, and therefore nalmefene may be an interesting drug to try in an elderly population. The only problem with nalmefene is that it has not been studied fully, and therefore further studies are needed to validate its potential efficacy. Now we turn our attention to another type of drug. These are drugs that work on the glutamate system, which is mediated by a neurochemical called N-methyl D-aspartate. This neurochemical is particularly involved in mediating the intoxicating and the cognitive effects of alcohol. It is also a system that is highly involved in forming dependence because these glutamate receptors change their characteristics depending upon chronic drinking. And so it seems reasonable that you'd expect if you gave an antagonist to this glutamate system, you would reduce alcohol craving, particularly in people who have been drinking for a long time and then they stop their drinking abruptly. The panel on the left-hand side shows basically a figure of a neuronal cell body, and in there's a hypothesized description of how a camprosate works. The truth is, we don't really know exactly how it works, but we have several ideas. We know that it works through probably these fast ion channels or these voltage-gated calcium ion channels, decreasing their sensitivity. Their sensitivity is increased in patients withdrawing, and this is one of the reasons why people have withdrawal symptoms. Also, it suppresses this glutamate activity, which is also associated with some of the anxiety most people feel while they're withdrawing. So one good way of giving a camprosate is to administer it to people who are trying to get off alcohol and who may be suffering from withdrawal symptoms. On the left-hand panel of this diagram is an explanation of a pooled series of double-blind studies mostly conducted in Europe showing the effectiveness of topiramate. On the y-axis is the percentage of patients with continuous abstinence, and on the x-axis is the time in study in days. The graph is divided into two sections. The first 360 days is when patients were actually treated, and then these patients were followed up for another year, ending up with 720 days. These data are fairly consistent, and they do show that twice as many patients who receive a camprosate versus those who take placebo remain abstinent at 1 year. There are at present no published negative studies on the effectiveness of a camprosate, and a camprosate is widely used in Europe for the treatment of alcohol dependence. Now, a camprosate is not without its own problems, which may be of particular relevance to the elderly population. Okay, sorry for that interruption due to technical problems. We seem to now be back. And hopefully I can remember where I was giving this presentation. But we're just about to start talking about serotonergic agents, which are a set of medications which we really have spent a lot of time in San Antonio developing. Serotonin is a very interesting neurochemical, and because it regulates so many things, regulates the physiology of sleep, body rhythms, mood, eating behaviors, addictive behaviors, sexual behaviors. And in fact, when we started studying serotonergic agents for the treatment of alcoholism, one of the things most people said is, well, you know, this neurochemical does so many things, but it doesn't do anything at all, and maybe you folks are just chasing a red herring. Well, what has happened is that that thought and our diligence in tracking down what serotonin actually does has proved to be a very interesting story. And so the reason why serotonin is involved in so many processes is not because it is irrelevant, it's because it's actually very, very important. In fact, it's more or less like the pacemaker of the brain along with the dopaminergic system. Basically, what happened was there was a series of studies, and the series of studies suggested one thing. They suggested that there were people who had a family history of alcoholism, and that these people had some kind of low levels of serotonin or this neurotransmitter. And therefore, the earlier research suggested that, well, all we need to do is to give these people some more serotonin in the form of antidepressants, and they would get better because the serotonin levels would go up, and what could be easier? Well, what happened was when these studies were done, approximately 10 years ago, the patients actually got worse. And so everybody was puzzled because if you actually went to measure the level, it was low, and you gave more and the patient got worse. One of the things that our group has done that has advanced the field is to suggest an important advance, I think, in the understanding of this process. Rather than saying that the level is low because we measured it as low, is to say the level is dysfunctional, and it only appears low because we are measuring it in the periphery, not measuring it in the brain. And once you get past that and you believe that it is a problem of regulation rather than a problem of amount, then the solution appears a little bit easier. And what we did was we basically took two types of alcoholic. We took a set of alcoholics who had a high degree of a family history and this very high biological component to the alcoholism, and we compared those with people who developed alcoholism later on in life, usually as a consequence of all sorts of problems. And what we found was that although you can demonstrate that these patients do differ in the periphery in terms of serotonergic function, if you gave a specific drug called ondansetron, which actually is an antagonist, so now you have two negatives in the equation, it actually produced a positive result. And the positive result which it produced was it was an effective treatment for these early onset alcoholics. Now, if you did the reverse and you gave the drug which was the agonist, which was the reuptake inhibitor, what it did was it helped those who are late onset alcoholics. So now you have two pieces of a jigsaw puzzle which seem to make sense when you do both sides of the experiment. And this is actually an important lesson in clinical science and also in the clinical practice, that most of us, when we're looking at treating diseases, we spend a lot of time thinking about what will make it better, but we actually spend less time on what would make it worse and use that information to help us design better drugs to get things to go well. And this is a good example of this. And so basically the story is now getting more and more confirmed. And the story is that if you have this early type of alcoholism, you respond to one type of serotonergic agent. If you have a different type of alcoholism which occurs later in life, you respond to a different type of serotonergic medication, and both of which are specific. The importance of this work is that our group has now been able to discern how we can identify those people earlier on in the path of their alcoholic process before they've had 15, 20, 30 years of drinking. This slide basically gives an understanding of some of the basic processes of this drug called ondansetron, which I've just been talking about, and its interaction with the dopamine system. But what is particularly important is for me to show you some of the treatment slides. And the treatment slides on the left-hand side of this panel shows the mean drinks per day, and these are the different doses of ondansetron: 0, 1, 4, and 16 micrograms per kilogram BID. These are extremely small doses because these are 4,000th of a gram. And this medication had to be compounded specially at our university and then dosed by body weight. What this shows is that compared to the 0 dose or the placebo dose, the individuals who are receiving 1, 4, or 16 are drinking less. And depending on how you look at it, whether you look at it at abstinence or how many drinks people have on each particular day, you can show the results. If you also measure this with a biochemical marker like carbohydrate deficient transferrin, which is a way in which you can take a blood test to determine whether somebody is drinking, these results are in the same direction. So whether the individual tells you by self-report that they are getting better, or whether you determine it by blood test, the drug has a therapeutic effect. Now this slide, which is the Clinical Science 3 slide, basically tries to give an understanding of what we've been working at. This is an example of two cells. The cell on the left is of course a presynaptic cell, and the cell on the right is a postsynaptic cell. And on the presynaptic cell there is a transporter called the serotonin transporter. The serotonin transporter in these early onset alcoholics are more numerous than those with the late onset alcoholism. So what they do is they take serotonin from inside this intrasynaptic space, reduce the levels, and make the postsynaptic cells more sensitive. What ondansetron does is it comes over and blocks these postsynaptic cells. Now, why is this important? It's important because the regulation of the transporter is under genetic control. And by using a relatively simple genetic test, you can determine who is likely to be one of these early onset alcoholic and who may be more likely to be one of these late onset alcoholic, apart from just getting a history from them. And so what we're doing at the current time is trying to make these genetic tests a lot better and to see whether we can predict prospectively who will benefit from a particular treatment and then give it to them. In the case of patients who are elderly, they're much more likely to be of the late onset variety, although we do have some patients who have the early onset variety. But this is where this dichotomy is very important, because if you simply if you simply expect that because somebody is older, then they have the late onset alcoholism, and you give them ondansetron, they will get worse. And so knowing when the person started to drink and have a problem from drinking is an important question in both the young population and also in the elderly. And it's very, very important to deciding which medication to give. Well, not all serotonergic agents seem to work, and that's particularly important because it attests to the specificity of the treatment response. For example, we've tried another drug called ritanserin, which is a blocker of the 5-HT2 of the serotonin system. It didn't do very much. Others have also tried a drug which works on the 5-HT1A system, and that also doesn't seem to work. And so this effect of serotonergic agents is very, very specific. Approximately a year and a half ago, a colleague of mine decided to test our hypothesis even further. If it was that these early onset alcoholics, or these early people who develop drinking problems early, have these abnormalities, then the more drugs we give specifically designed at these abnormalities should increase the treatment response. And so what we needed to do was to do a small study, not a very big study, because if the treatment response was getting larger, then we should see the effect using a small sample. So this is an extremely small sample of only 20 subjects, and they're receiving ondansetron and naltrexone. You'll remember naltrexone was a drug which helped people who had possibly a positive family history. Ondansetron is another drug which is helpful to people who have a positive family history of alcoholism. So if you give the two together, you should expect a big response. This is exactly what happened. The y-axis is the mean drinks per day, and the x-axis is the study weeks. The study only ran for 8 weeks. And it is very, very interesting to see that even at 8 weeks, you get significant results of differences between the placebo, which is the group in red, and the blue, which is the ondansetron and naltrexone combination. What we're currently doing at UTESCA is to replicate this study in a larger sample, but also look at the independent effects of ondansetron and naltrexone in the same study. And that component of the study has been funded by NIH, and we're currently working on it. Well, the excitement about combining medications for different medications for treating alcoholism is very important. And there are many good reasons for doing this. First of all, as I've discussed, we can boost treatment response, but also sometimes the side effects of the two medications, if you give them properly, can cancel one another out. This is particularly important if the side effects you get are things like dizziness or headache or stomach upset, which really can be incapacitating for almost anybody, but will be particularly incapacitating for people who may be frail. And therefore it's particularly important for us to pursue these avenues. Unfortunately, a lot of these studies have not been done in the elderly, and in fact, one of the aspects of this research that I believe that needs to improve is our need to replicate and conduct these studies in special populations. The National Institutes is currently sponsoring an 11-site clinical trial which we're part of to try and basically combine different types of medication. That study has been ongoing for 4 years, and we hope to have results in another 2. So it takes a long time to develop a drug, and sometimes as much as 10 to 15 years, but I think we'll get there in 6. Well, what do we have in future? What we have in future is to begin to develop more powerful medications for treating alcoholism. The last 5 to 10 years have been particularly important because it has produced a lot of excitement. Now we need to see whether we can get many more people better. On average, if people come into a treatment program and they wish to stop drinking, about 50% of them can be expected to improve. We've been able with these new drugs to get the number up to about 70%. And I'm hoping that in the future we'll have this up to around about the level of most treatments in general medicine, about 80 to 85%, which would be a tremendous advance. The other thing that is important is that we have pioneered in San Antonio is testing many doses of the medication. And that has been particularly important because we want to find the dose that is most effective, but we also want to find the smallest dose that is effective. This is going to allow us to give the drug to different populations of patients rather than simply give one big dose to everybody. The other important things that we're doing is we're going back to studying these subtypes question more closely. Now we know that there are 2 neurochemicals in the process. There may be 3, there may be 4. And this may mean that eventually we will need to combine many types of medication, as is done in cancer treatments, to get the best treatment response out for people who are alcoholic or who may have alcohol abuse problems. In closing, I want to thank the sponsors for inviting me to give this talk, and I hope it's been enjoyable.
Thank you. It was most informative.
Yes. Very exciting to know this is going on. It's
All happening at UTESC.
yes,
Blood is
yes.
coming to UTESC.
That's marvelous.
I guess really looking for something for the older people. Back in January, we had a speaker, and his own substance abuse for the older. He had nothing before that. It was people above 65. And that's what I'm hearing here, that we don't really have anything for over 65. Where do we stand there?
I think it's a problem. I think most studies have excluded elderly patients, which I think that they should not. But a lot of these medications are highly experimental, and therefore the idea has been to test a younger population first before trying it out in the elderly. But now some of the studies that have been going on are now about 8 to 9 years old, and therefore I think it is time that we can expand these studies for different age populations. But you're right, there are very few studies, but this is not only isolated to addiction field, it's for all types of treatment, whether it's blood pressure or cancer treatments. Younger people tend to be enrolled more into clinical studies.
That's true.
And the elderly are the forgotten population in terms of drinking.
So what have they known, what have they found about it genetically? Is it genetically inclined, alcoholism?
Yes, we know that about 60% of alcoholism is genetic, which is very interesting, because if you were in this field about 20 years ago, you'd have said, well, it's all to do with the person's personality. Mm-hmm. But now we know it's actually mostly genetic. And so even for people who develop the disease later on in life, they could have inherited the genetic predisposition earlier on in life, and they didn't know about it. They had other diseases or disorders.
How do you explain somebody, let's say you have 2 people, and one of them can just stop like that and the other one can't, besides genetically?
Well, it depends on what the circumstances are. I mean, assuming that they're both drinking exactly the same, it depends on how tolerant they are, first of all. I mean, if one person is more tolerant to the effects of alcohol, then they're going to have fewer symptoms in quitting to take alcohol. And therefore, that person may be able to stop a lot easier. I mean, we all know people, if you take 2 or 3 friends who go to a bar and they drink about the same amount, and one is dancing on the table and the others are having a sober conversation, it's because we all have different rates of handling alcohol. And so the rate in which our liver can break down alcohol does differ between individuals. It differs by body size and also differs by gender. And so all these things are important. Also, in the elderly, one of the important things is because they have less body water, the intoxicating effects of alcohol are more acute. And it's the same for women. So if you're an elderly woman and you are drinking, then you're going to feel intoxicated much more quickly than any other population.
I think sometime in the past I had read, if I can remember correctly, and correct me if I'm wrong, if you have there's the female, the daughter, with an alcoholic father, it's more likely that the daughter will become an alcoholic than the son?
No, the research is, that's a good question. The research has actually changed a bit. and I can tell you very briefly what the research is. The research that was done 20 years ago was actually done by some of the research was done by a friend of mine, Bob Cloninger. What that showed was that, who's a native of Texas, what that showed was that the sons of alcoholic fathers were much more likely to develop alcoholism, but that study did not study women. Now, in the last 5 to 7 years, there have been studies in women. And what that shows is that women are also just as vulnerable. And in fact, some of the studies being done here at UTESCA by myself and my colleague Dr. A. Dowd have shown something more, that when women get the alcohol disease in terms of a biological disease, they are more severe than their male counterparts. And that you would expect, because there are many social ways in which women are more rapidly helped than males, and drunkenness is less likely to be tolerated in women than males. So the cases are more severe when we see them in our clinic. They're females.
So compared to substance abuse, what would be the percentage that you think would get cured with alcoholism? Compare substance, you know, I mean, like, because I used to work in a rehab. We had cocaine addiction, heroin addiction, just you can name it, and we had it. And our cure rate, you know, I mean, was like, well, not cure, you're never really cured, but where you're going to be without any drugs was like 3%, which was very
No, it's not as terrible as that
depressing.
in alcoholism. And 3% may be pessimistic even for substance abuse in general. I think that the rates of somebody being totally free from alcohol, if that's the definition, those rates are probably about a quarter of people indefinitely on psychosocial help. With medication, it may be as much as 40%. So you're getting close to half the people better from. But if you're looking at it in a different way, if you're looking at getting people abstinent, but also including people who are not severely incapacitated from the effects of alcohol, that figure rises to about 70% with people on medication. So it's actually considerably higher. So
That's
there
good to know.
is a good deal of hope in these treatments, and there's a good deal of promise that they'll become even more effective.
It's very encouraging.
Back a number of years ago,
Very.
I saw a survey that was done that daughters of alcoholics, at a very high percentage, will marry an alcoholic. And after he dies, she will marry another. Have you found anything lately showing that? Now, this was back in the early 60s, about the time we declared alcoholism as a disease rather than as low moral characters. And we made that switch over. That was about the time that came out. I wonder if there's anything lately been done to see if that carries through, and if so, why?
Well, a lot of the addiction literature shows that most people with addictions tend to get associated with other people who have addictions, because addictions tend to be all-consuming, and they tend to be salient in the person's life. And therefore, if you spend most of your time drinking, you're going to associate with other people who are drinking. And so I don't think there's a biological reason for that. I think it's one of association, that there's a group, and you associate with a group who also drinks, because otherwise you appear to be odd and you don't fit in that group.
Makes sense.
Yep.
We do thank you so much.
That was very good, very
Thank you.
informative. Thank you.
And the audience was small, but very appreciative.
Very much so.
The computer wasn't appreciated.
Well,
I wish you had a handout. It's very
I
interesting.
have them. I can
Oh,
print
you
them
have
out.
them?
I can print them
Oh,
out.
okay.